Today, I would like to welcome one of our new colleagues, Dr. John Pennycuff. Before joining us, Dr. Pennycuff received his MPH from Tulane University School of Public Health and Tropical Medicine. He then received his MD from Emory University School of Medicine and stayed at Emory to complete his residency in OBGYN. He then went on to fellowship in female pelvic medicine and reconstructive surgery at MedStar Washington Hospital Center and Georgetown University. And we are very glad to welcome him here to the Division of FPRS. His research interests are super interesting, including maternal obstetric trauma, urinary biomarkers, obstetric anal sphincter injury, and pelvic health after breast cancer. Please join me in giving a virtual welcome to Dr. Pennycuff this morning.
Good morning. I'm absolutely delighted to be here. I asked that I be able to give a grand rounds earlier in the year so that I would get a chance to meet more of y'all, and also for individuals here at Madison to sort of understand some of the research that I'm interested in and want to continue to do. And maybe promote some collaboration. So I'll be talking today on onco-urogynecology, which is really pelvic health, intimate well-being, and cancer survivorship. This is the code. Oh, are we moving? We're not moving. There we go. This is the code for grand rounds, as Dr. Bazudos mentioned. And these are my disclosures. So my objectives today are fourfold. I want to define cancer survivorship and explore the role that the gynecologist has in delivering cancer survivorship care. I want to discuss the prevalence of pelvic floor disorders and their severity when it's known among GYN cancer survivors. And I'm going to place particular emphasis on breast cancer survivors since that's my area of interest. I want to talk about some of the unique aspects of treatment among this population, and then also identify some knowledge gaps and next steps for future research. So when I developed this talk a couple years ago, I never know who's in the audience. So I start really basic for any learners or trainees that may not exactly understand what we're talking about or what we're defining. So pelvic floor disorders are things like pelvic organ prolapse, urinary incontinence, and fecal incontinence. And overall, the prevalence is about 1 in 4 in the US population. As women age, the prevalence increases to 1 in 3 for women who are 50 or older, and 1 in 2 for women who are 80 or older. And there's about an 11% lifetime risk of needing a pelvic floor surgery. So this gives you an idea of how prevalent these disorders are in the United States population as a whole. I want to sort of just shift a little bit and sort of introduce the idea of cancer survivorship and what that means. In the United States in 2016, there were about 8 million female cancer survivors. And this number is expected to increase as time goes on. So by 2026, we expect about 10.3 million female survivors. And you see actually that GYN cancers are among the top survivors. So breast cancer make the largest population of cancer survivors, followed by endometrial cancer. Then we go down to cervical cancer and ovarian cancer. And you see that the GYN cancers, including breast, are among the top 10. We have about 3.6 million breast cancer survivors in 2016, expected to be 4.5 in 2026, and that number recently released is going to be over 5 million in 2030. So a big number of breast cancer survivors, and very likely that these patients could come to your clinic with certain complaints or medical issues. We know that, unfortunately, rates of breast cancer are going up, particularly among young women. You can, as evidenced by this sort of salmon color line here. But the good news is that women who are diagnosed with breast cancer are living longer, so mortality is decreasing. A good statistic to remember among this population is that greater than 90% of women who are diagnosed with breast cancer will live at least 5 years after their diagnosis. So that really sets the stage for what exactly cancer survivorship care is and its importance. And so it used to be that cancer survivorship was what we considered once a woman was said to be free of cancer or that her cancer was cured. But now we have a much more nuanced and a much more rich understanding of cancer survivorship care, and it's sort of put into three buckets. The first is the acute phase, which is the diagnosis to the end of treatment, and a woman is focusing on the treatment aspect of cancer care. The extended phase is after treatment, for months after, and the focus is generally on the effects of cancer and treatment on her body and recovery from that. And then the permanent phase of cancer survivorship care lasts years after the end of treatment, and the focus is on long-term effects of cancer and treatment, and includes more things like quality of life, return to work, return to daily activities, things of that nature. So it's the idea that you're living through cancer and beyond cancer. And there are many points of insult to the pelvic floor during cancer treatment. This can be surgery, this can be chemotherapy, radiation, and particularly for breast cancer, that can be endocrine therapy or the medicines that are given to prevent recurrence. We know that chemotherapy has been reported there with bladder toxicities, particularly for carboplatin and cyclophosphamide. Urgency and frequency has not really been described after chemotherapy, but we're still not sure. We know that cisplatin and vincristine are neurotoxic, so certainly it makes sense that administration of these agents could lead to nerve damage to the bladder. There was a study that showed that bladder symptoms were 4 times more common with a cyclophosphamide methotrexate fluorouracil regimen compared to Adriamycin cyclophosphamide. But then another study came out by Alfonso and al. Found no relationship to the type of chemotherapy or surgery. So you can see that there's a lot of discrepancies. There seems to be equivocal findings, and I think that this is an area that's really ripe for research in the future. We know that pelvic radiation reduces bladder compliance through inducing fibrosis. A study done in the 80s showed that very high rates of urgency or urgent continence after radiation, as well as frequency and nocturia. We know that women who undergo pelvic radiation have decreased bladder capacity. They may have a much lower first sensation volume and then higher pressures or a less compliant bladder system. Radiation has also been associated with stress incontinence and intrinsic sphincter deficiency. And interestingly, this is from a SEER database, the SEER database. Women who received radiation for endometrial cancer had more late bladder toxicity and hematuria and incontinence than those than matched controls without radiation. So this is pretty compelling. All right, sorry about that. We know that pelvic radiation reduces changes to the vaginal epithelium. It causes mucosal atrophy and fibrosis, so it would also cause atrophy of the vaginal epithelium. There's a reduction in vaginal length as well as elasticity and a reduction in lubrication. And this all has implications for sexual dysfunction. And we know that about 67% of women who have had pelvic radiation experience some sort of dyspareunia. A lot of superficial dyspareunia, but also deep dyspareunia. And these numbers are very, very high. When we think about GYN oncology patients, we sort of want to get a sense of what do these women experience after their treatment. Interestingly, the kind of first study, or one of the studies that's often cited, looked at GYN oncology patients before they had treatment. So they looked at about 550 patients, and about 2/3 of them had a GYN malignancy. Most of it was uterine, followed by ovarian, and then cervical. And then they compared it to 200 women who had a benign gynecologic condition. And they found that both women were similar in terms of BMI and parity, but the women were a little bit older in the cancer group. And so they asked these women about their pelvic floor symptoms prior to cancer treatment. And you see that women can come in as with pretty high rates of pelvic floor disorders, a lot of urinary incontinence, about 10% reported prolapse, which is a little higher than the general population. And about a third of these said that they were moderate to severe. And symptoms and severity seem to be similar across cancer type. And there was really no difference compared to the benign group. So the study was sort of helpful because we're starting to talk about it, but it really doesn't tell us anything about the role that cancer treatment has in terms of pelvic floor disorders. It tells us more that there are pre-existing pelvic floor disorders that patients with cancer have, and possibly about how cancer might affect the pelvic floor. And I'll talk a little bit more about sort of the pre-existing pelvic floor disorders that patients with cancer might have later. But I think a lot of us in urogynecology have had a patient who's come in with acute onset prolapse, and when you get a history, you're like, this doesn't make sense. And this is a patient I definitely had in fellowship. She came into clinic like 6 months of acute onset prolapse, had great support before then, and she actually had acute prolapse because of ascites from carcinomatosis. And so, I think it's just important to remember that certainly cancer can cause these symptoms, but more importantly, a lot of women come in with these symptoms prior to cancer. So this study was sort of not a great study, but it was the first to look at different types of pelvic floor disorders among different types of GYN cancer. So it included 160 women who were diagnosed with endometrial cancer, cervical cancer, ovarian cancer, and vulvar cancer. And they completed a battery of validated questionnaires to assess for pelvic floor disorders, like especially urinary incontinence, as well as their overall well-being and their quality of life. And they were completed before cancer treatment and then about 6 months after. And you do see that there are changes, that women experience incontinence prior to treatment, but then there was an increase. And then this is also pelvic organ prolapse. More or less stayed the same. They accounted for, again, some de novo incontinence and pelvic organ prolapse after. And again, this is not a great study. I wouldn't hang my hat on any of this, but at least we're starting to talk about it. What they found, though, which I think is interesting, is there were significant changes in a validated questionnaire called the UDI-6, which assesses presence and severity of urinary symptoms, as well as the Incontinence Impact Questionnaire 7, among women who'd had a TAH, THBSO with lymph nodes, radical hysterectomy, and debulking. However, this was not seen with a bulbectomy. And the MCID for the UDI-6 is 11, and for the IIQ-7 is 16. So you see that these changes pre and post cancer are clinically meaningful. And they were clinically meaningful for all surgery modalities except bulbectomy, which sort of intuitively makes sense. They found that chemotherapy alone did not negatively affect quality of life, that adjuvant radiation and chemoradiation was found to worsen certain subdomains for incontinence. And then there really was no difference in the UDI-6, the IIQ-7, or the short form 36, which is a questionnaire of overall well-being, between surgery alone and surgery with adjuvant therapy. And I think that that's an interesting finding. So there was a big systematic review that was done that looked at pelvic floor disorders among women with GYN malignancies. For cervical cancer, we kind of have not a lot of data. You see that there are high rates of incontinence, and they're highest for women who undergo radical hysterectomy with chemo or radiation. Lower rates if nerve-sparing hysterectomy is done. Stress incontinence and urge incontinence are all quite high, and you can see the breakdown there. Fecal incontinence is quite high as well. And then sexual dysfunction, as expected, occurs in a lot of these patients, probably due to the radiation. Endometrial cancer we have a little bit more data for this group, particularly for pre-treatment. You see that a lot of women do come in with urinary symptoms. Post-treatment, their rates seem to be a little bit higher. You can see that stress incontinence is high, and even higher if women have radiation. Urgent incontinence as well, higher in those women who undergo surgery and radiation. There have been some large trials that show that radiation is associated with more severe symptoms and has a greater impact on quality of life. And then again, these larger trials also showed that chemotherapy probably does not contribute to urge incontinence or urinary incontinence. As previously noted, sexual dysfunction is very common. And it makes sense that this group has a significant amount of urinary symptoms because obesity is both a risk factor for endometrial carcinoma as well as urinary symptoms. And it should be noted that this study by Ertz et al. Is the only prospective cohort study. So, I put this together probably 6-8 months ago, and at the time, that was the most up-to-date literature search that I had, and only one prospective cohort study. So, I mean, there's just so much research that can be done in this field. Here's another study that was done by a urogynecologist who's now in Kansas City. He looked at pelvic floor disorders and quality of life measures postoperatively with endometrial cancer survivors. And this is the only study to assess pelvic organ prolapse in this cohort. They found that pelvic organ prolapse is pretty common, about 44%. And then there's a study that was done by Thomas et al. That showed that baseline, probably the percentage of prolapse among endometrial cancer survivors before treatment is about 7%. So yeah, you can't really compare these studies because you're not comparing apples to apples, but I think it is compelling that high rates of pelvic organ prolapse after surgery and rates pre-surgery similar to the general population. Ovarian cancer, finally, what we'll finish up with is the cohort for which we have the least amount of data. You find that there are some numbers, a lot of urge symptoms, urge incontinence, urinary incontinence symptoms. You see pelvic organ prolapse numbers similar to the general population, high rates of fecal incontinence, and then sexual dysfunction is very, very high. So I do want to switch gears a little bit and start discussing breast cancer survivorship care because that's my area of interest. In the United States, there are about 3.8 million women who are living with a history of breast cancer. Over 300,000 diagnoses occur annually. And it's interesting because breast cancer is a little bit different than other cancers because women will take SERMs or aromatase inhibitors to reduce the recurrence risk. About 70 to 80% of breast cancer is hormone receptor positive. And so a high number of these women could potentially be on these medications. It's not known exactly how many women take endocrine therapy, but just 10 million women alone are eligible for chemoprevention, the idea that they're high risk. And so they would be taking these medications to prevent the development of breast cancer. These medications have a very anti-estrogenic effect. SERMs don't allow the estrogen to bind to tissue or bind to receptors, I should say. And aromatase inhibitors prevent the peripheral conversion of circulating androgens to estrogen. So they have a very strong anti-estrogen effect. And so that, again, is a potential insult to pelvic well-being. We know that greater than 60% of postmenopausal breast cancer survivors report vaginal symptoms of dryness, irritation, pruritus, and dyspareunia. And this is probably about 20% higher in breast cancer survivors than in matched postmenopausal women without breast cancer. And these symptoms are often least stressed because, and I think it's really important that we talk to our patients about pelvic health and intimate well-being. Because they may not consider that their breast cancer has treatments for quality of life issues after the cancer, or they may feel like, well, I just have to deal with this because I had cancer and they saved my life. And it's interesting because sexuality is the most robustly researched aspect of sort of pelvic health and as it relates to breast cancer survivorship care, but still it's very poorly addressed.
Oh yeah. Yeah.
We know that aromatase inhibitors are the biggest risk factor for sexual dysfunction. Surgical modality has not been associated with sexual dysfunction, but I'll talk a little bit about that later. And then chemotherapy and radiation are also not have not been associated as well, although there is some previous data that maybe suggests the opposite. So I'm going to give a few clinical pearls here because I think, it's good to talk. For me, it's very interesting to talk about my research, but I think a lot of people want to get some clinical pearls, and that the societies, ACOG, OGS, NAMS, they all recommend first-line treatment of sexual dysfunction with non-hormonal vaginal moisturizers and lubricants. And I think, and I certainly did not know this until I started doing this research, there are recommendations about how we provide counseling on those sort of products. The WHO recommends that osmolality not exceed 380 milliosms per kilogram. And there are actually very few commercially available moisturizers and lubricants that are on the market that fall under 380. So like the things like KY or Swiss Navy, these things that are on the market at the CVS or the Walgreens, all are actually very hyperosmotic, and that can be that can induce irritation and also like have a detergent effect on the tissue and can cause tissue damage, which further exacerbates the symptoms. There are some brands that fall under the 380 milliosmoles. The role of pH is even less well understood, but you want a product that not only falls under the 380 threshold, but also is balanced to the pH of the vagina. So, somewhere between 3.8 and 4.5. And there are some very, very acidic products on the market that are commercially available that are like in the sort of area of like 2.5 to 3, and that can also be quite irritating potentially to the tissue. There are also a lot of inactive ingredients that are in sort of products that are made to have a shelf life. These things are parabens it's a common preservative. They're weakly estrogenic. Their role is as an endocrine disruptor is being more heavily investigated, and they have been detected in breast cancer, but their role in carcinogenesis is not clear. Glycols are added to make the product feel more slippery. And there are studies that show that could increase your susceptibility to certain STIs and also kill lactobacilli. And there's an increased risk for BV as well as being a food source for Candida albicans. And so, when patients come in sometimes with like recurrent vaginitis, I always ask about their lubricant or moisturizer uses. And, we try and change things. And then chlorhexidine has been found to increase transmission of STIs, and that's a common preservative as well, or it's a bacteriostatic agent to prolong shelf life of these at room temperature. So WHO recommendations are here, and I'm going to focus just on the breast cancer piece, which is this last row. So you want to use a paraben-free vaginal moisturizer that falls under 380 milliosmoles per kilogram and has an acidic pH to match the vagina, and it should be paraben-free. Remember that vaginal moisturizers are used 3 times a week, just like a facial moisturizer would be, to bring water to the tissue. And then lubricants are used at the time of intercourse, particularly to reduce friction. And your lubricant should also fall under the same guidelines as vaginal moisturizers. I think there's a lot of questions on breast cancer and estrogen, and the more data we accumulate, I think the more questions arise. The data on systemic HRT and recurrence are conflicting. The Stockholm trial done in Scandinavia showed no increased risk for breast cancer, whereas the Habits trial showed higher risk of breast cancer events with HRT. I think everyone kind of feels, okay, HRT for breast cancer survivors systemic is a no-go. But where do we stand on vaginal estrogen? there's concern for systemic absorption, right? Like we know that some estrogen is absorbed systemically, particularly within the first 2 weeks. You should never get a systemic level higher than the postmenopausal range. But if a woman is on a SERM or particularly an aromatase inhibitor, the goal is to get her as close to zero circulating estrogen as possible. So what is the role of vaginal estrogen then? We know that local estrogen is highly effective for genitourinary syndrome of menopause with minimal systemic absorption. The data is pretty convincing that there's no increase in primary breast cancer recurrence, and has no effect on mortality. A little bit less data for endometrial and ovarian cancers, but probably is beneficial. And we know that estrogen is safe in cervical, vaginal, and vulvar cancers because those are not driven by estrogen, they're driven by HPV by and large. And again, I recognize my limitations as a female pelvic medicine doctor talking about cancer. And so I'm always open to the oncologists who are much more in touch with this literature saying, hey, actually, we have a study, or actually, have you considered this? But, this is a pretty good review that came out in 2020 where I'm getting this information. But if there's newer literature or the oncologists in the room have thoughts, I'm happy to, very, very grateful to hear that. But what about other pelvic floor disorders? So moving beyond sexuality. We know that there's a decrease in the tensile strength of the uterosacral ligament in primates when they're on SERMs. There's a study that looked at women who went on tamoxifen and found that there was worsening of pelvic organ prolapse on tamoxifen and raloxifene compared to conjugated equine estrogens and placebo. There are no studies on aromatase inhibitors, and these results remain controversial. I think sort of what prompted me to get interested in this is I knew a lot of women who were diagnosed with breast cancer, and they said, yeah, the minute I took that tamoxifen, or the minute I took that anastrozole, like I just felt like everything fell out. And so I wanted to sort of do research to see, if that is borne out in data. We know that lower urinary tract symptoms are common, so urinary symptoms are common among breast cancer survivors, 12 to 58%. And these symptoms are associated with less vitality, worse physical quality of life, worse social life, and overall worse quality of life beyond physical. And that urinary symptoms definitely have an adverse effect on sexuality in the postoperative treatment. So this is a study that I did while I was at Georgetown. And MedStar is actually a 10-hospital regional system in the Mid-Atlantic. And so what we did as a team is we looked at every woman that had a diagnosis of breast cancer in the system. And then we did propensity score matching to women who had no diagnosis of breast cancer and had never been on any sort of tamoxifen or anastrozole, and they had to have at least 6 visits in the system to sort of match for health-seeking behavior. And I recognize that there are some methodologic concerns in this study because you're only looking at people who come access care in a healthcare system, but you're able to get large numbers, which was nice. And then once we figured out our population, we looked at the prevalence of pelvic floor disorders overall, stress incontinence, pelvic organ prolapse, those who had mesh complications, fecal incontinence, urge incontinence, and then lower urinary tract symptoms without incontinence. And you see, compared to healthy controls, matched controls, breast cancer survivors have lower rates of pelvic floor disorders overall, low rates of stress incontinence, low rates of pelvic organ prolapse. And so this is statistically significant for all except mesh complications. So we then looked at the association of endocrine therapy by pelvic floor type, and we found that SERMs were associated with stress incontinence and pelvic organ prolapse, while aromatase inhibitors were associated with stress incontinence, pelvic organ prolapse, fecal incontinence, and urinary symptoms. The estrogen antagonists were associated with fecal incontinence and urinary symptoms. And then thankfully GnRH and agonists, I should say, I apologize, were not associated with pelvic floor disorders, which is good because we use them for other things in much younger women. But that really only gives you, it's retrospective, it's only those women who are seeking care, and there are methodologic concerns about that. So the next study that we did was looking at cross-sectionally at women who were breast cancer survivors. And this is some older data. I'm about to update this with the full cohort of 303 women. But what you see is that these numbers are much higher in breast cancer survivors than what the retrospective study showed. And bothersome symptoms are also much higher and maybe higher than the general population. And so chemotherapy was associated with some prolapse as well as fecal incontinence. And then endocrine therapy was associated as well with a vaginal bulge question. So this data is going to be updated. It's my next project. But moving across the country and getting set up as an attending sort of put a little bit of pause on this. But now that things are sort of, the dust is settling, this is my next project to tackle finishing. We also looked at sexuality using the FSFI. And we stratified the cohort by those who are over 50 and those who are under 50. Based on the sort of the age of when a natural, like a sort of normal menopause would occur. And we found that younger women did have higher scores, and that was statistically significant, but these numbers are very, very low. Any number that's less than 26 on the FSFI is a woman who is at high risk for sexual dysfunction. And you see that the SF12, which is a marker of emotional and physical health, is similar between these two cohorts. So, that helps us understand, like, is the sexual dysfunction because of a physical or mental health problem that might be impacting sexuality? But these women are similar. A lot of pain, a decrease in desire and arousal. Interestingly, we'll have to see what the full cohort looks like because we're moving towards something. But lubrication was similar between the two groups. But again, I think once we have the full cohort, we may see something different. So then I had a wonderful medical student that helped me with this. And what we did for these women is we stratified women by what sort of surgical modality that they got. Because, the sexuality piece could be because of a SERM, or it could be because of the treatment they got and their body issue or their relationship with the cancer or things of that nature. So we wanted to see if surgical modality had a role in not only pelvic floor disorders, but also sexuality. And it's really interesting. About 40% had a lumpectomy and 50% had a mastectomy with reconstruction. And a very small portion, about 8% had a mastectomy without reconstruction. Half these women received chemotherapy, and about 75% had an exposure to some sort of endocrine therapy. Women who underwent a lumpectomy were more likely to have radiation and less likely to have received chemotherapy. But otherwise, there were no differences between the groups regarding exposure to endocrine therapy. The only thing is that women who underwent a lumpectomy were more likely to take a aromatase inhibitor. So really, you see that there's no difference in the composite scores for pelvic floor disorders. When you sort of break out into subscores, you see the only significant finding is that women who have a lumpectomy have lower scores, so less, and a mastectomy with recon have less urinary symptoms compared to women with mastectomy alone. And then in terms of the sexuality scores, lowest scores were actually among lumpectomy, which I thought was really interesting because this is breast. Remember, this cohort is breast conserving, and then also there's equal sort of exposure to endocrine therapies, although these women are more likely to be on an aromatase inhibitor. And I think that, that really helps inform us about women who are getting this type of treatment for their breast cancer. All right. And similar scores for mental component as well as, or the emotional component as well as the physical component for the SF-12. We then looked at surgical interventions and found that when women are diagnosed with breast cancer and pelvic floor disorders, they have similar rates of pelvic floor surgeries between the groups, higher rates of prolapse surgery and hysterectomy among the breast cancer survivors, which may indicate that they have more bother. And the hysterectomy may be concerns about intrauterine pathology for being on tamoxifen, or there could be some overlap with wanting a hysterectomy or sort of cancer genetic syndromes, things of that nature. We weren't really able to parse that out. And then no difference for rates of surgery for stress incontinence or mesh complications between the groups. And this sort of gives you a hazard ratio, and you can see kind of how, rates, your risk of getting a hysterectomy in the breast cancer group is higher, prolapse surgery as well. So because these endocrine therapies are associated with some pelvic floor disorders, might they also be associated with recurrence of pelvic floor disorders after surgery? So we looked at women who had a history of breast cancer and underwent pelvic organ prolapse and stress incontinence procedures and followed them out for a mean time of 14.6 months. Overall failure was similar to the general population. The only interesting finding is that our obliterative procedures had a pretty high failure rate compared to like what we tend to cite, but overall these failure rates kind of match or are lower than the general population. Endocrine therapy at the time of surgery was not associated with prolapse or stress incontinence recurrence, and then endocrine therapy was not associated with any intraoperative complications, postoperative complications, or readmissions. So there's a lot of limitations with the data that I presented that from my research as well as from the body of literature. These are really heterogeneous studies with heterogeneous outcomes. Most of the studies are cross-sectional and don't allow for comparators. And there's a lack of consensus on outcome measures. The oncologists may use one set of measures, whereas I use another set of measures, whereas a population or public health researcher may use a different set of measures. And so there's really not been consensus to my knowledge on what we should be using or not be using. And the pelvic floor disorders questionnaires that I use have not been validated in cancer survivors. And so that does call into question how generalizable this data is. But I think it's important that we can continue to do the research. Survivors are living longer life, and cancer care and survivorship care is becoming a mainstay of cancer treatment. We know that cancer and pelvic floor disorders affect quality of life, and patients want their providers to ask about sexual symptoms. But doctors prefer if the patients bring this up to us, and I think what it really boils down to is, do we have the tools? We as doctors have to be, as providers, have to be asking the questions and advocating for our patients. I think there's a really interesting study that was done by Doyle et al. 42% of women in the GYN oncology practice reported being bothered by pelvic floor disorders, but a very small minority of these women accepted referral to a urogynecologist. And the most often cited reason for refusal was feeling overwhelmed by their current diagnosis. There were financial concerns. And then these, I think, are really important that we address, is that there's a belief that oncologic treatment would cure pelvic floor symptoms. There's a concern about time constraints, or a belief that urogynecologic care would delay their cancer treatment. Interestingly, studies have found that there are higher levels of interest in urogynecologic care once an oncologist acknowledges the presence of a pelvic floor disorder and recommends urogynecologic care. In a qualitative study, gynecologic cancer survivors reported that they would undergo care for their pelvic floor symptoms if it was deemed effective and recommended by their healthcare provider. And so this is, I think, an area where we can really collaborate together, the people who practice pelvic floor health as well as the individuals who practice cancer care. So there are some things we can do. We can reduce risk at the time of oncologic treatment. I know that in our procedure, or in our field right now, we're talking about nerve-sparing procedures and introducing more nerve-sparing procedures. I also think that there's some studies, there are very few studies, but studies showing that there can be concomitant urogyne and GYN oncology procedures that are done when possible. Only about 2.4% of GYN oncology surgeries done nationally are done with a FPMRS individual. And given how prevalent pelvic floor disorders are among women with GYN cancers, I think this number could increase. And there's only, in terms of complications, there's only been shown to be a modest increase in transfusion, which is among ovarian cancer patients, but otherwise there's no difference. And again, I'm not saying if you're doing a huge debulking that we should also do a repair of pelvic organ prolapse. But if you have a stage 1 endometrial cancer, could we also place a sling at the same time? Would that be safe to do? So we can also screen for pelvic floor disorders among our cancer survivors, and then familiarize ourselves with the high-yield evidence-based recommendations for pelvic floor disorder care. And this was, the last point has already been done here at UW, and so I know that it's, you all are very familiar with this concept of establishing and referral to a multidisciplinary comprehensive cancer survivorship clinic, which you have a WISH clinic here, have the WISH clinic here. But this is like a very new and foreign concept for many institutions around the country. And so just starting to have those connections and those relationships between different disciplines to provide multidisciplinary care, I think is really important. We should also not only provide multidisciplinary care, but establish multidisciplinary research collaborations. And we have to include breast cancer survivors as representatives on these panels and when we think about the protocols that we write and establish for doing research. I think a lot of times, the researchers think about the research they're going to do, and they don't think about the patients or the individuals that would be contributing to the research. And actually, research becomes much more acceptable to breast cancer survivors if they're included in the research protocol and development. We need large prospective studies or registries among breast cancer patients to evaluate pelvic health longitudinally. And I think we also really need to evaluate and address disparities in cancer survivorship care. We know that there are disparities, particularly racial and socioeconomic disparities in cancer care, but we need to understand that these exist in cancer survivorship care as well. We need to better delineate the role of chemotherapy in pelvic floor symptoms and see if these symptoms are responsive to interventions. And we need to improve quality of life outcomes for survivors receiving care from survivorship clinics. And our goal should be to develop interventions that reduce the sequelae of cancer treatment that can be done either after completion of cancer treatment or concurrently with. So I would like to thank the University of Wisconsin OB/GYN Grand Rounds Committee, as well as a bunch of people and institutions that have helped me along my research journey. Research is never done alone. It's always done collaboratively and never one person responsible. And I had a whole team, a whole family of people who helped make my research happen. So I'd be happy to answer questions at this time, and I hope there's some good discussion.
John, that was really excellent. Anyone with any questions? Heidi's giving you lots of emojis here, but anyone with any questions on the phone?
John, this is Dobie. I have a question about scheduling.
Yes.
Everybody has a set schedule and such. what barriers do you see between if somebody in oncology is seen today and you have ovarian cancer, you need to have surgery next week, and the barriers for testing for stress incontinence and stuff like that on such a short timeline?
Definitely. So again, I think if someone's emerged, so definitely there are barriers. Like OR block time is different. We often, our testing requires weeks. If you need a urodynamic study before you do a sling or something of that nature, or prolapse repair, that might be weeks out because we treat benign diseases. And so sort of the decision from diagnosis to OR time is different among GYN oncologists versus urogynecologists. But I think it's more important that we get beyond like yes, we can identify the barriers, but then we can also say, okay, how can we improve some of these barriers, right? And so I think that there are some patients who, hey, they have no prolapse, endometrial cancer, have cough stress test positive. That's a patient who could get a sling at the same time as her endometrial cancer hysterectomy. So I'm not saying we may not be able to get every patient to have concomitant surgeries, but if we can at least start to think about it, like, oh, would this maybe benefit? Could we also do a suspension procedure at the same time as her hysterectomy? So it's just to think about it and form that collaboration.
Hi, John. It's Ellen Hertenbach. I have a kind of a follow-up question to Dobie's. And first, I just want to congratulate you on all the work you've already done in this area. And I just think it's really a 21st century concept to take care of more than the cancer and really take care of all of the side effects of therapy and really pay attention to survivorship issues. I guess my question is there a really kind of sort of quick and dirty questionnaire or set of circumstances where kind of an upfront referral while we're in the middle of the cancer care planning is more appropriate than kind of down the line? There's a lot going on for these ladies and some of our previous urogynecology colleagues that we worked with said, take care of the cancer and send them to me later type of thing. So is there a really direct way, not just a set of diagnoses, but even tools or some kind of a questionnaire or just something, some really quick and dirty, 3 key questions or 3 key diagnoses? Because as you can imagine, patients are just overwhelmed with their cancer diagnosis when they're first coming in to see us.
Yeah, I mean, I think you make a really good point. And I think the minute you say cancer to a patient, like I think there's like a sort of a blackout period where you don't hear much else. And so I think you're absolutely right. You're overwhelmed. You've just got a cancer diagnosis. And now suddenly someone's, well, what about your pelvic health? And do you feel a vaginal bulge? And do you have leakage of urine? Sort of our quick and dirty like screening tool is 20 questions. I recognize that is a lot. I think if we could get patients who are new patients to the GYN oncology, like to a GYN oncology practice, to fill out the PFDI 20, that would be good, because there are certain questions that we could say, okay, yeah, definitely referral to urogynecology, but also would give you information on their pelvic sort of symptoms, pre-treatment, and had implications for research down the road. So I think that's a pretty good tool. It's 1 page. It can be done pretty quickly. And then could have robust data, not only for referrals, but also research. And I think, just a study of the acceptability of do patients, do they find it acceptable to ask about pelvic floor symptoms on a new GYN oncology visit? I mean, I don't think we even know that. And so, I think we're really at step 1 in terms of evaluating these things.
Yeah, Ellen, I agree. This is Laura. I agree with your comments, and that, in the breast cancer treatment world, or young cancer patients, we include fertility preservation as part of their treatment, and asking them about their reproductive goals and things like that as part of their initial treatment planning. And so this could be something that's similar, where you ask, it may not be the most important part of their cancer treatment, but it's something that you assess at the time of their intake and whether or not that needs to be incorporated into their treatment planning. So
And
there's some precedent in that regard.
And I think my thing is, I would never want treatment of a pelvic floor disorder to delay cancer care, but I think I just want to advocate for women to be able to address these things and not just say, well, I can't deal with this because I just have to focus on my cancer and I just have to live with this because that prolapse or that stress incontinence isn't going to kill me. And I think sometimes cancer care, in my experience, has sort of shifted the notion of, well, I can just deal with this because I'm not going to die from it. And, I just want to be able to improve quality of life.
Yeah, I think you're right. I think making it part of standard intake, I think is a great idea. There's a lot of things we do that way now. And, I think you make great points.
Yeah, not only that, but discontinuation of aromatase inhibitors and endocrine therapy in general. There's a lot robust literature about patient not taking their entire course of 5 years or now even 10 years of endocrine therapy because of bothersome symptoms and how infrequently those are discussed with their providers. So I think John starting to address those may be a way also to encourage compliance with treatment.
And I think it's probably been overlooked the number of endocrine therapies we use in the gynecologic malignancies as well, and increasingly so.
Definitely.
Well, I think we are at time here. I didn't see any questions in the chat, but this was a great discussion and a great presentation. And thank you so much, John, for presenting this morning.
Thank you.
All right. Enjoy your days, everyone.